For the every phacosurgeon, it is challenging to handle the capsular access of an intumescent cataract. So during the surgery of an intumescent cataract, both surgeon as well as anti-lens capsule is I am always called Miss Capsulina are under equal tension. All of us being the ophthalmic surgeon have experienced surgeon tension at the certain point of time. So now let us see what the capsule feels.
Who is crying?
Hey Doctor, it's me, the Lance capsule. You know, I was already handling so much of pressure. And you also made the same Argentina flag on me like other surgeons do? So I thought that I am in the safest hands. But what happened to you, doctor, today? Now, doctor, please and please find some way and manage me anyhow.
Don't worry, you are still in the safest hand. I will try my level best to manage you and will try give you the best possible result. If the axis is going radial toward periphery, what to do? Immediately stop performing the axis, fill the antechamber with high molecular weight viscoelastics and make sure nothing is pressing on the globe like finger, lid speculum and sometimes patient squeezing the lid. Small cuts via the bonus seizure in the peripheral upper and lower part of the torn axis and use the atrata forceps to complete the both semicircles. Avoid perpendicular forces against the capsular tear, nucleus divided with soft vertical chop or sculpting technique in the iris plane. Most appropriate supracapsular phacoemulsification and parameter should be low. After removing the cortex, IOL implantation should be in the back and placing the haptic perpendicular to the tear. As the saying goes, prevention better than cure. So how to avoid Argentina flag sign? First, be mentally prepared. I prefer to use IV mannitol in most of my intumescent cases pre-operatively, and I use high molecular weight viscoelastics. I usually follow the modified capsule axis technique.
So for the double axis, initial puncture and aspirate the liquefied cortex, and initially we make a small axis and then make a cut with the help of the bonus seizure and then make another secondary axis in the circular fashion. So you can make an initial 4 mm rhexis and then emulsify the nucleus and then make a rhexis after the implantation of the IOL. In the spiral capsular axis, after initial nick and aspiration up, you make an initial small axis but not complete, and then at the point of completion we put a slightly tangential force and make a spiral axis. Then the axis extend one side only, so we make another nick opposite side of the extension. It should be the perpendicular to the limbus, and then make a cut in the center in the inverted T fashion and then complete the axis. You can make initial nick in the cross fascian and then reduce the pressure. You can make a axis slightly fast so you can run before extension. When the pupil is small, you always use the ring.
Thank you, doctor. Now I realized that where there is a will, there is a way. Thank you.
For the better outcome, by applying the modified technique, modify capsule axis, phaco chop, avoid stressful clacking, we always used supracapsular phacomultiplication with lower parameter. So gentlemen, wipe out Argentinian flag from our mind and salute to our Indian flag. Jai Hind. Thank you.